Good evening, everyone. Myself, Dr. Praful Rakholiya, Gastroenterologist at Gujarat Hospital. Sorry for delay due to some network issues. Today we will discuss regarding hepatic encephalopathy. This is for PG students. Okay, so hepatic encephalopathy, it is uh, defined as brain dysfunction, which is caused by liver insufficiency or photosystemic shunt, and it manifests as a wide spectrum of neurological and psychiatric abnormalities, which range from subclinical alteration to the coma. The pathophysiology behind this clinical condition is hepatocellular function, or it may be because of photosystemic shunt. And the physiology will be because of the gut-derived neurotoxins, brain water homeostasis, or oxidative nitrosative stress, or astrocyte dysfunction, or maybe because of neurotransmitter dysfunction. So the main neurotransmitter is the ammonia, which leads to cognitive dysfunction in a patient with hepatic encephalopathy. Normally, it is produced in cirrhosis. It is produced in the gut by bacterial dysbiosis, and also it is produced from the skeletal muscle tissue background, which is more in the cirrhotic patient. And this increased ammonia level is not filtered out by the liver, and then it goes into the systemic circulation and goes to brain. But most of the ammonia go through into the systemic circulation via shunts, like varices development in the cirrhosis leads to shunts, and which increases the transmission of ammonia from venous system, portal system to systemic system. First is the gut-derived neurotransmitters are ammonia, which is the main transmitter which is responsible for the neurological dysfunction. Others are mercaptans and short and medium chain fatty acids and GABA and, and octapamides. The brown water homeostasis, how it is done, means ammonia is utilized by the glutamate, and it converts into the glutamine, and this glutamine leads to development of astrocyte swelling, and this leads to dysfunction of the neuronal system. So increased ammonia level will use glutamate and converts to glutamine, and which is responsible for neurological dysfunction. And oxidative stress, this ammonia also leads to oxidative stress in the neuronal cells, and which is mediated by NMDA receptors. And astrocyte dysfunction, as we discussed, because of swelling of astrocyte, and there is a dysfunction in the protein tyrosine nitration, and it leads to decreased transmission of intracellular signal and leads to astrocyte dysfunction. Neuronal transmitter dysfunction, in which there is a shift in balance of inhibitory and excitatory neurotransmitter transmission toward the inhibitory. So there will be an increase in GABAergic tone, which leads to depression of the brain cell functions, and thus it leads to neurological dysfunction. And also there will be decrease in acetylcholine level. So now, what are the precipitating factors of hepatic encephalopathy? So in any conditions where there is reduction in the fluid of body fluid, or there is imbalance in the electrolytes, which will lead to development of hepatic encephalopathy, like in GI bleed, infections, and excess protein in diet, which leads to development of more synthesis of ammonia, and which get absorbed from the intestine and then it leads to hepatic encephalopathy. Electrolyte dysfunctions, which occurs in patients who are on diuretics. Constipation also leads to develop increased synthesis of ammonia, and thus it leads to development of HE. Dehydration in patients with cirrhosis who have ascites. These patients will be on fluid restriction, will be on diuretics, and may require sometimes paracentesis for the ascites. So all these things leads to dehydration, and then uh, there will development of HE. So patients who have ascites are more at the development of more risk of development of HE. And alcohol misuse also leads to HE. And other cause is the TIPS insertion, which increases the bypass of ammonia from portal system to systemic circulation and increases the HE. Now, classification of HE. It is classified by in three, four types of classification is there. One is according to the underlying disease which causes HE. It is classified as type A, B, and C. In A, it develops in patient with acute liver failure, which occurs because of, and usually it is associated with increased ICT and risk of cerebral herniation. Type B is occurs in bypass or in shunt. It's portosystemic bypass or shunt. Patients who have undergone in TIPS or who have varices and like that. C occurs in patients with cirrhosis of liver. So it is a C occurs in chronic liver disease. A type means it occurs in acute liver disease, and B is classified in patients with bypass. According to time course, episodic HE, which occurs once in a year or twice or biannually, while recurrent HE, which denotes bouts of HE that occurs within time interval of 6 months or less, and persistent HE, in which there will be a pattern of behavior alteration that are always present, but it is interspersed with relapse of overt hepatic encephalopathy. Other classification is West Haven classification, which is classified in grade 0 minimum and 1 to 4. And other one more classification is the Sonic classification, which is classified as unimpaired. Other is a covert hepatic encephalopathy and overt hepatic encephalopathy. In overt hepatic encephalopathy, patient will have symptoms like change in sleep wake. Patient will have a lethargy, bizarre changes in the behavior and cognitive dysfunctions. While in overt HE, patient will have a many minor symptoms which we may not diagnose, uh, and for that we need some neurological tests to diagnose the covert hepatic encephalopathy. So these are the various classifications of hepatic encephalopathy. Now, clinical features. In minimal hepatic encephalopathy, there will be affection of attention span, and patients there is a deficit in working memory. Then patients will have a psychomotor deficiency, and also in a visual spatial ability deficiency that we can diagnose with some test. Patient will not have any symptoms in minimal HE. In minimal HEs, patient may have sometimes Asterixis or flapping tremors, which presents in early stage of HE, usually in early stage, but may present in other stages of HE also. It will be the earliest sign or of development of HE, in which there will be a rapid flexion extension movement at MCP and wrist joint with lateral movements of a finger. So we can test Asterixis in the ankle. Their myoclonus will be there at the ankle joint. Asterixis is also seen in uremia, ventilatory failure like CO2 narcosis, and some drug intoxications like barbiturates, phenytoin, and alcoholism, and also some electrolyte imbalance like hypokalemia, hypomagnesemia, and hypoglycemia. So must put this differential diagnosis when we have diagnosed patient with Asterixis. So this is how we will do a Flapic test. Other features or symptoms will be fetor hepaticus, in which patient will have a sore, musty, and a feculent smell uh, on the breath, which is due to presence of mercaptans, which is byproduct of methionine metabolism. In personality changes, there will be apathy, irritability. Patients will have euphoria or disinfect inhibition, and patient will have behavior like childish behavior, and there will be loss of concern for the family and friends, and will be in a depressed state. And intellectual disorientations, in which patient will have slight impairment of mental function to grow confusion, and there will be a constitutional apraxia, and also there will be change in the handwriting. So we can use a pen paper test to diagnose this intellectual deterioration, in which we will ask patient to write or draw some uh, pictures like star, and we'll ask him to do the same, draw same picture, and he will not able to do the things. Disturbed consciousness, in which patient will have change in the sleep pattern, in which patient will have a daytime sleep, and this is the earliest sign of development of HE. And patient's speech will also will be slow, slurred, and voice will be monotonous. In motor system, patient will have hypertonia, hyperreflexia, and Babinski signs will be positive. Patient will also have some extrapyramidal dysfunctions like hypomimia, is muscular rigidity, bradykinesia, hypokinesia, and sometimes Parkinsonism like tremors will be there. Now, prevalence. So, minimal HE and covert HE, which occurs in 20 to 80% of patients with cirrhosis. So, this overt HE will be more common, while the prevalence of overt HE, like 10 to 14%, will be present in the patient with cirrhosis at the time of diagnosis, while 16 to 21% will be present in a patient with decompensated cirrhosis, and 10 to 15% in patients who have TIPS. So patients with cirrhosis who have underwent TIPS have increased risk of development of HE. It is ranges from 10 to 50%, but it will be more 20 to 25% usually. The diagnosis of HE is very easy when in patient with cirrhosis, because they have a precipitating factors, and if there are symptoms like Asterixis. But diagnosis becomes a challenge in patients who have not have above symptoms. So in that case, there will be need some other tests to differentiate it. So according to ASLD guideline, diagnosis of HE is thorough exclusion of other cause of brain dysfunction. So to diagnose HE, first we have to rule out other causes of brain dysfunctions like stroke or meningitis or other electrolyte disturbance. So differential diagnosis of HE most common will be like metabolic, like electrolyte dysfunctions, and sometimes hypoxia or hypercapnia. In CNS, there will be a stroke or subdural hematoma or bleeds. While toxins like CNS depressants or alcohol patients who have Wernicke-Korsakoff syndrome, and infections like sepsis, which leads to development of some neurological dysfunctions. But in these cases, the following tests will be aid in diagnosis. First is a thorough neurological examinations, in which patient's mental state, memory is changed, and in patients with stroke or bleed, in that patient will have a motor dysfunction also in later stage. But the most common blood investigation will do is arterial ammonia level, which is not sensitive or specific, but the high level of ammonia can indicates HE in absence of cirrhosis and portal hypertension. Special test for minimal hepatic encephalopathy. These are a portosystemic encephalopathy syndrome test, uh, which is a paper pencil test, as we already discussed it. The second is a critical flicker frequency test, in which fused uh, light appears to be flickering to the observer. Means we will keep a fused light, and patient will observe that light, and he will feel that uh, light is flickering at some specific uh, hertz of unit of the light. So mostly, if patient have this flickering at 60 hertz, usually it is less than a 40 hertz, then we can say that patient is having a hepatic encephalopathy. And third is a continuous reaction time test. In that, repeated registration of motor reaction time is calculated to auditory stimuli. So these three are the commonly used tests. And other, the inhibitory control test, which is a computerized test in which response of inhibition and working memory is tested. And the Stroop test is a and scan test and electroencephalography test are difficult to do, and these are usually not done. But these three tests are computerized tests. So this is a paper pencil test. The other thing we can do is EEG, in which in most common finding in EEG will be triphasic wave, or there will be a rhythmic delta activity, which is seen in more severe grade of encephalopathy. This triphasic wave is not pathognomic, but it is also observed in other metabolic encephalopathy, but which it can lead, we can uh, if it is present in patients with cirrhosis, then we can say that it is HE. And radiological test, CT, MRI, usually we do to rule out other causes of cerebral dysfunction. But there will be manganese deposition in globus pallidus in patients with cirrhosis. So we can find some abnormality in CT or MRI. Other test we can do is MRS and PET scan. So now we'll come to treatment. So in treatment, the elimination or correction of precipitating factors will be the first line of treatment. We have to first diagnose what are the precipitating factors, and then we have to do is we have to reduce ammonia level in blood. So for reduction of ammonia level, we will use non-absorbable disaccharides, antibiotics like rifaximin, oral branch chain amino acids, IV lornithine and aspartate, probiotics and other antibiotics. Third, nutritional, and the last option will be liver transplantation in patients who have persistent hepatic encephalopathy. So non-absorbable disaccharide. This is the treatment to reduce ammonia level. And first, we have to correct precipitating factors, like if patient is having hypokalemia, hyponatremia, then we have to correct that one. Or patient is having bleeding, then we have to start antibiotic to prevent hepatic encephalopathy. And if patient is on diuretic with electrolyte disturbance, then we have to stop diuretic. So lactulose or lactitol is the first choice of treatment. So there are two approved therapy for HE. One is the use of lactitol or lactulose. Second is local antibiotic rifaximin. These are two ASLD approved treatment. So how this lactulose will work? So it is a synthetic disaccharide and which is converted to monosaccharide, then and plus volatile fatty acid and hydrogen ion and methane. So this volatile fatty acid will be uh, used by bacteria for a substrate, means non-pathogenic bacteria. So non-pathogenic bacterial growth will be there and which forms stool bulk. And this H plus ion will increase the acidity of the fluid, and in this acidic environment, pathogenic bacteria will not survive. And one more thing, this decreased pH will convert ammonia to ammonium ion. So I mean convert ammonium ion to ammonia, which will not be uh, absorbed from the small bowel. And this acidic pH will also decrease proliferation of harmful bacteria. And it also acts as a probiotic, helps growth of good bacteria, and reduction of intestinal ammonium production will be reduced by inhibition of glutaminase activity. So the dose will be 15 to 20 ml, 2 to 4 times per day. But what we have to do is we'll ask patient to pass 2 to 3 soft stools per day, and we'll like that we will adjust the dose of lactulose. It can be given by rectal enema, but data suggests that the rectal enema has not that much role. Second is the antibiotic, which is a proven therapy for HE, like rifaximin, which aims modifying the intestinal flora. Means it selectively eliminates urease producing bacteria. So it is effective as an add-on therapy to lactulose for prevention of overt hepatic encephalopathy. And other antibiotics instead of rifaximin, we can use metronidazole or neomycin. This oral branch chain fatty acids, these are not that much. The use of this BCAA is not that much proven, but still we can use this oral BCCAA, which have little benefit in reducing ammonia level and reducing episodes of hepatic encephalopathy. This will improve the manifestation of episodic HE, whether it is overt or minimum. L-arnitine L-aspartate. This is also given by intravenously or oral route, but usually we'll give it intravenously if patient is indoor. In which sort of amino acid arnitine and aspartic acid, it provides key substrate to and promote metabolic pathway like urea cycle, and which results in detoxification of ammonia level. But because it increases uh, urea cycle function, so we must see urea level of this patient. If it is more than 100, then we should not give L-arnitine. But if urea level is less than 100, then we can start L-arnitine, L-aspartate. So we should take precaution before starting LOLA. Other drug is S-carbose. So we are not using, but it has a function like it inhibits intestinal absorption of carbohydrate and glucose, and which results in enhanced delivery to the colon. So the ratio of saccharolytic to proteolytic bacterial flora is increased, and thus ammonia level will be decreased in blood. Other drugs which can increase the ammonia clearance. These are sodium benzoate, sodium phenylbutyrate, sodium phenylacetate, but these are not available in market. Uh, Zinc supplementation. There will be zinc deficiency in patients with cirrhosis. So poor zinc level will impair activity of urea cycle enzyme, and for that we need zinc. And by this zinc supplementation, we can increase urea cycle. We can decrease ammonia level. Probiotics, which promotes non-immunogenic bacteria in the gut, and thus it increases the bulk. Forms bulk of the stool. In patients who are having a persistent hepatic encephalopathy or patients who does not improve with standard treatment, so in that case we can either go for liver transplantation or artificial liver support system. Most commonly, it is required in patients who have acute liver failure who underwent in hepatic encephalopathy. In that case, we need either artificial liver support system or liver transplantation. This artificial liver system, like Mars, this is a molecular absorption recirculating system. It purifies blood by removal of albumin-bound and water-soluble molecules, and also it removes ammonia, endotoxin, and inflammatory mediators. It is like dialysis. In patients with hepatic encephalopathy, that nutrition is also have to maintain nutrition in this patient because patients with cirrhosis will be malnourished, and in that case there will be loss of muscle mass and there will be increased production of ammonia. So in that case, since we have to provide 35 to 40 kilocalorie per kg body weight energy intake, and protein intake should be 1.2 to 1.5 gram per kg per day. And patient is also advised to take small meals or liquid nutritional supplements which is evenly distributed throughout the day, and at late night snacks should be offered in this patient because these patients of cirrhosis are more prone to development of hypoglycemia. And vegetable proteins are better tolerated than animal proteins, so patients are advised to take vegetable proteins more in diet. Thank you. If you have any questions, you can put questions, or any doubt, you can write it in the check box. Thank you.